Okay, should we start or should we wait for some time?
So election wait করুন.
Okay.
We have to wait for a few minutes.
Hello.
Doctor.
Okay, now there are 58. Shall I start? Hello?
Was it, sir?
Am I audible?
Yes, sir.
Okay, now I'm starting, okay?
Okay, sir.
Okay, so today is very basic topic. So I think when we were medical student, there at that time there was only surgery. So urology as such, especially in our country, it was not developed, but maybe after 15 or 20 years, now it has very much well developed subject in surgeries. So before learning anything new, we should know about what exactly it is. So it was very much part of surgery for a long time. So when you read about this subject, then the root has been to the Greek and Roman origin. So actually pretty much it was the domain of surgery there. So there are few students of your batch who were with me in the clinic, and I try to explain them how the field of surgery evolved during this period. So how they are named is very important. Basically, there are two branches in two division of medical field. One is medicine and one is surgical field. So with the time, they have developed into the more specialized subject. So how they name, we call them as a cardiac surgery, GI surgery or orthopedic surgery, so many there. The name itself, it is a bit atypical, like we want to introduce ourselves as a urologist or urology. So what is the difference? Because there is something called cardiology and cardiac surgery, or there is a neurosurgery or neurology. Okay. So this is kind of misnomer in urology. We now people also call it a new neurosurgery, but basically it's a urology. And another counterpart of this subject in the medicine is nephrology. So as a medical student, after this class, you should be very much clear what the two different subjects are. So urology basically is a surgical aspect of kidney disease. Okay, whenever I ask them, they just say that there is something related to urine, kidney, so they make their own definition. So what are the main domain which we work? Is like mentioned here, it's a kidney, adrenal gland, ureter, urinary bladder, urethra, and whole male reproductive organ. So any surgical issue and some medical issue. So why it is called urology? This is just a tradition which we are carrying on. So there is no particular reason why it is called urology, but you don't be confused with urology with the medical subject. Okay, it's a surgical field. So that is what I want to make it clear. And this is the organ which we deal with. Now, by the time we introduce this subject of urology, now urology itself has divided into so many things. Like in this slide, you can see there are urodynamic disorder, means something related to lower urinary tract. So people in this my clinic, I try to explain there are two kind of tract: upper urinary tract and the lower urinary tract. Upper tract means is the kidney and the disorder of the ureter. So lower tract means disease of bladder and the urethra. There is oncology, stone disease. So it's very important now. Maybe if you look at the audit, and 80% of our job is directly or indirectly related to stone disease. So that is the bulk which we see in this our clinic. Okay. Then there is a reconstructive surgery. Means reconstructive means some defect has been there from congenital or from any surgical procedure or trauma, and we want to repair them with the reconstruction. And pediatric is a different field altogether. Andrology related to male reproductive organ. Just a minute. Hello. Sajid, bana. साइज कत्रो भनेछ साइज कत्रो भनेछ साइज साइज कत्रो भनेछ साइज क्लटको साइज यसो गर न युरिन आइरहेछ अहिले फ्लस गर्दै गर त्यस्तो भयो भने फुल्ली चेन्ज गरे पनि हुन्छ नभए भोलि हामी एकचोटी त्यसलाई गर्दिउँला क्लियर गर्दिउँला फ्लस गरेर Okay, and now other branch we have started is the renal transplantation. We do in our medical college also we have started this. Hello? सचित म क्लासमा छु क्लास लिँदैछु यसो गर न तिमी त्यो भयो फ्लस गर्नु त्यो गाह्रो भयो भने चेन्ज गरे हुन्छ भोलि आएर हामी क्लट निकाल्दिउँ न है ल Okay, so before we start anything, the most important thing is the anatomy. Okay, we should know what it is. So kidney is the main structure. So if you look at the figure, and you should study kind of anatomy with the figure. So without figure you cannot study anatomy. So if you look at this thing, so many schematic figure you can see. This is the gross anatomy of the figure. So it's very important landmark is the psoas muscle. So it just sits nicely over the psoas muscle, and in the right side there is liver, That's why the right kidney is a bit lower, 4 or 5 centimeter lower than left kidney. Weight, depending on the person, it is about 125 to 170 gram, a bit smaller in the women. Size, so size is very important, 10 to 12 centimeter long, and this is the width. So if kidney is small, maybe kidney is less than 9 or 8 centimeter, then we think that, okay, it's not functioning that well. So if it's less than 5 or 6, then it is not functioning at all. So size is very important. So this is the first thing you should look in the kidney. And they are supported by the different layer of fats called perinephric fat. And it's mobile in inspiration. During the respiratory movement, it moves down. So it's very important during while performing the surgery. So that is the importance of gross anatomy. So if you cut the kidney, so it's a basically revision of your anatomical class. So it's the dark area is the medulla and a bit brighter side is the cortex. So if you cut it in the half, then you can see cortex and medulla, and there is a separate thing called pelvic calyxal system. So it is very important. So why? So there are so many structures there, they lie in the cortex and the medulla. And there is something called column of Burton. So you can see here. So this is the medulla, and this some structure that is similar to cortex that goes in between two medulla. So that is called column of Burton. And medulla is consists of numerous pyramids. So these are the pyramids, and this is the medulla. Okay. So in the cortex, there are so many vital structures, and the medulla, there are. We'll talk about them later. So it is individual. Now, other important thing is what surrounds the kidney. So that is very important from the surgical point of view. So now, how clinically your knowledge of anatomy is applied. So that is here. Okay. For example, now there is stone disease. Okay. So how anatomy is important. So stone disease, they come in the pelvic calyxal system. Okay, here. Now, so what we do, now we puncture the kidney from here, somewhere here outside. So look at this. So it is surrounded by liver, intestine, colon, jejunum, so many things come here. So if you puncture the kidney through liver, then patient will die. Okay, if you make the hole from intestine, and it's a disaster. So here the importance of anatomy. So you should know which part is the vacant one, and you have to make some puncture from this side. So it is regarding one procedure. So there are so many things. Now, suppose there is kidney malignancy. So if it is cancer in this area, then it will easily go towards the colon. If it's here, then it will go towards the liver. So surrounding anatomy is very much important clinically. So this is the transverse section of kidney. Now, if you cut the kidney along with the other abdominal structure, then how well they are protected now? So this is the kidney. We have the 3 layers of muscle, abdominal muscle, external oblique, internal oblique, and transverse. This is anterior laterally. Now, there is posterior muscle, and this is a spine. This is psoas muscle, so many muscles. So it's very boring while you only study the anatomy, but it makes a hell lot of sense when you operate on the patient or when you talk about the patient. This knowledge is really helpful. Now there are big vessels like IVC, vena cava, adrenal artery, adrenal vein. So why it's important now? While surgery, suppose I'm doing donor nephrectomy. So I should have all the knowledge of where this artery is, where this vein is, what are the muscles which I am cutting. Then I can safely remove this kidney. Okay. So this is how it is important. So we are talking just about the gross anatomy. Now another important thing is the nephron. So you all know this is the MCQ question. The functional unit of the kidney is nephron. Why it is called so? So we have got 1 million nephron. So all this nephron, they work for distinct function. So basically nephron has 2, secretory and excretory. So what is the difference between secretion and the excretion is? Excretion means, excrete means you have to go through some filtration. Okay, again, the like in glomerulus, there is high blood pressure, and with that pressure, some amount of our body byproduct that get excreted means against the force. Secrete means there are secretory function means that basically the endocrine functions. Okay, like the secretion of some glands. Like that, the kidney also they secrete. It's not against the force, but it's against the some like active transport, which you study in the medicine, physiology. So secretory function is within the cortex now. The secretory function is within the cortex and it consists of renal corpuscle, whereas the excretory portion is lies in the medulla. So this how this kidney, this nephron they placed. The secretion is in cortex. So that means this one Bowman's capsules, they all lies in the cortex, whereas all these tubules they lies in the medulla. Look at this. Renal corpuscle is composed of vascular glomerulus and Bowman's capsule. Okay, and they goes towards these tubules. They goes towards the medulla. So this is all minute details of nephrons. The secretory portion is made up of proximal tubules, loop of Henle, and distal, where excretory is of collecting tubules, and which is in continuous with the distal end of ascending loop of convoluted limbs. And all this product, now there is glomerulus, now there is excretion, and all these products go to proximal convoluted tubules, distal convoluted tubules, and all these products they have to go through the pelvic calyxes system, and from there goes to the bladder. So what is the entry point from where these tubules get access to pelvic calyx system is the tip of papilla. In the picture I can show you. So this is one unit. Okay, this is a nephron, and this is all these tubules and all this thing. And all through the papilla, they go towards this one, pelvic calyxal system. From here, then urine forms and go through the ureter and towards the bladder. Okay, this is how it's a one nephron. There are 1 million nephron in this kidney. We are talking about just one unit. And so this is the magnified view of glomerulus, and how glomerulus is a bit busy slide, but you have to go through your histology lectures to understand more in minute details. And there is renal stroma, supporting tissue between this nephrons. So they are not just hanging like that. They have to be supported by some renal stroma, that is loose connective tissue, and they consist of blood vessels, capillaries, nerve, and lymphatics. So blood supply is very important. Now you have to remember there is abdominal aorta. From the abdominal aorta, usually you have one renal artery, but that is only in 60 to 70%. So 20 to 30% people, they usually have 2 artery or 3 artery, multiple arteries. So why it is important? It is even more important where we are taking the kidney. If somebody is giving kidney, then we don't know there is 1 or 2 artery, then we can just think that there is 1 artery and we can make chop this other artery. Then means if you cut this artery, then this kidney function will be compromised. So before taking out kidney, we have to be very much sure that how many arteries are there. It's important during nephrectomy also. If you just tie one branch, and if you left other branch, then the bleeding will be there. So amount of artery is very important. And the people will ask another questions is that what are the end arteries? So renal artery is one of the example of end artery. Means if you tie this artery main branch, then there is no other accessory supply. The kidney will die. Whereas maybe in this forearm, if you tie the radial artery, then the remaining supply can be from the ulnar artery. So that facility is not in the kidney. After this is the main artery like that, and after entry in the kidney, usually they are anterior and the posterior branch. They divide into two branches, and that posterior branch supplies the mid segment of posterior surface only, and remaining is from the upper pole, lower pole is from the anterior surface. So all renal arteries are the end arteries. So this is how the renal artery supplies. It's very nicely shown. And anteriorly is the anterior branch. So they are basically apical, upper, middle, lower. So they divide more inside the kidney. So why are study in detail right now? So anatomy you study without knowing that whether they are helpful, or you read everything. But now in the surgical field, you study the applied anatomy. So whatever we study, that is for reason. So why it's important of reading all this thing, where it's supply, what are this thing? The importance is that now, if somebody have to do partial nephrectomy, then we should know which artery is supplying which part of this kidney. Okay, so that's why it's important. And if somebody is puncturing kidney from this way, if there is some artery, if you hit this artery, then it is bleed like anything. And if we are removing the stone, then we have to remove the kidney also. That's why so many news you can see in the new media that while removing the stone, the kidney has been removed. Why? Because there are so many arteries. So you have to remove the stone very much, saving all these arteries. So that's why that is the importance, clinical importance of all this thing. So this is very busy slide. We don't need to know all these things, but just you can focus on the kidney. So this is how kidney is there, and see how closely red is the aorta, and this is the vena cava, and these are all the adrenal glands. This is a kidney, and so many things going here and there. So this is how kidney is located. Retroperitoneum. This is a retroperitoneal picture of the kidney. Now it is more important for the urologist how this segmental artery. So one renal artery, they divide into anterior and posterior branch, and that main branch divided into segment, where there are different segments in the kidney, and each segmental artery, how they divide. Look at this. This is called interlobar arteries. So interlobar arteries, and they further divide into arcuate arteries, and they further divide into interlobular artery, and that interlobular artery go into the glomerulus. It is really very difficult if you forget your basics. So whatever I tell you, you should be very inquisitive. Means you should know if there is glomerulus. We are talking about a very minute thing. Look, glomerulus means we are the one in the million thing we are talking about. Okay, so how the blood reach there? Look at this. So many divisions. So there is a million division of this artery, from main renal artery with series of division to interlobular artery, then gives the afferent arteriole, and that forms glomerulus. This is how the blood get access towards the glomerulus. Okay, so these are all the branches of artery. Similarly, venous. So usually, so what is difference between vein and the artery? Vein drain all the blood. Now, one difference is if you tie the adrenal artery, then the kidney is gone. But even if there is partial tie, or sometimes there is disease called renal cell carcinoma, that is tumor of the kidney. So it is notorious for throwing out thrombus. So usually they throw thrombus, and they occlude the renal vein. Even after that, the kidney can function, because the vein, they have their characteristic is that they develop common cells, means they have some other, if this drainage is blocked, then other accessory will develop and they can drain from other way out. Whereas artery had no that kind of luxury. So usually they have one renal vein, but you can have multiple vein. And one very famous question what examiner used to ask is that what is the venous drainage difference in venous drainage of left and the right? So what is difference in this picture is nicely shown. So this is the adrenal vein, this is the lumbar vein, and this is the gonadal. They all drain in the renal vein. So I think you are looking at my pointer. Lumbar vein, gonadal vein, and the adrenal vein. They enter in the renal vein. Whereas in this side, right side, they all enter directly into the vena cava, not in the renal vein. So that is the very important question. It is MBBS level question you will be asked. So it has got so many anatomical significance, but we'll not discuss that today. So this is very important. So as we are doing renal transplantation, our preferred kidney is left kidney, because if it is a left kidney, then we have got the kidney is there, the vena cava is on right side. So that means naturally they will have this long renal vein. So that is very much important. If it is a long renal vein, then we can comfortably attach to the recipient people. Okay, that's why we take right also, but our preferred kidney is left kidney, is because this renal vein is long. So that is the reason. So that is the anatomical significance of this one. Nerve supply. So nerve supply you should know. So again, if you have good knowledge of anatomy, then if this is a spinal cord and how the nerve they come and they supply different portion of this abdominal cavity. Now this is thoracic nerve, and there is lumbar, there is paranephric. So all this they supply the kidney. Now the pain sensitive part of the kidney is the capsule. So if there is the pain because of any urological problem, then the pain in the kidneys is because of stretch of capsule. So when there is a stretch, if there is some obstruction below, maybe in the kidney or ureter, anywhere there, because of a stone or any other lesion, if there is stretch in the kidney, then this capsule, then the patient have pain. So when there is pain, there should be some reflex arc. From there, these are the area of kidney, and these nerves, they take the sensation to the spinal cord, and that goes to the brain. Okay. So another example, so transplant is a very good example. Now you take out the kidney, but if there is some stone in the transplant patient, then there won't be any pain. Okay. Why there is no pain? Because we have divided all this nerve. They don't have any nerve, so they will not have pain if there is any stone disease or any hydronephrosis, any obstruction. So am I audible? Everybody is listening, or I'm just talking?
Yes, sir, you are audible.
Okay, so we have 10 minutes left, and we have to start again the same address. The lymphatic, during my MBBS, I used to realize that we really forget the lymphatic. Everybody, teacher will ask what is the nerve supply, what is the blood supply. Nobody asks the lymphatics. But if it is very important, it is important when you read about the malignancy. Okay. So they have the lymphatics, they drain in the lumbar lymph nodes. So these are the lymphatic. They are para-aortic, para-vena cava. From here, they go to the lumbar lymph node, and they go towards the upwards, and they go to the cisterna chylis or thoracic duct. So many that there. So what is the main important? This is example of lymphatic drainage of the left kidney. Look at this. The dark nodes, anterior, and the light nodes. Okay. Light nodes are the posterior one. The solid lines, they indicate the anterior lymphatic, and the dash, the posterior channel. And they all head towards the thoracic duct. Okay. From here, with this thing, they go to the thoracic duct. Why it is important now? Suppose the patient has renal cell carcinoma. So they, as I have mentioned in previous lecture there, the malignancy, they can transfer into two ways, by blood or the lymphatic. So blood is clear. So these are the lymphatic. From here, the patient can, tumor can go, the lymph node can form, and there is enlarged lymph node, and they can go to the liver or to the lungs. So these are very notorious for that. Now calyxes. So this is very important for urologists, because we basically deal with the problem in this calyxes. And every patient is different, and even both kidney are different. How they are different? Look at this. There are minor calyx, there is 8 to 12, and there are billions of possibilities how they are arranged. No two kidneys are absolutely same. Even the angle of this minor calyx differs. Forget about this, two different individuals. So how they are arranged is totally different. And what you should know as usually, so I tell usually because there are so many exceptions. There is pelvis also, sometimes two pelvis, but there is one pelvis, and usually there are 2 or 3 major calyx, and that major calyx divides into 8 to 12. So you should look at the picture, then you will understand this one. Look at this. This is the typical example. It doesn't mean that every calyx looks like this, but majority it looks like that. So it's very important in urology. So we play with this day in and day out. So this picture here is the kidney, cortex, and medulla, they surround. So we're talking about the pelvic calyces system also. This is the pelvis, this is the ureter, and junction is this one, uretero-pelvic junction. And even in this junction, there are so many pathology. One of that is pelvic uretero junction obstruction. Okay, now there is major calyx. This pelvis divides into 1, 2, 3. This is the major calyx. And this major calyx, they divide into minor calyx. Why we are discussing this much is, now the stone disease, stone can lie in any corner from here to here, whole areas. So one of the method of removing the stone is called PCNL, means we have to puncture this one from this minor calyx. Okay, from here, depends on where the stone is. So we should be very much sure of what is the configuration of this minor calyx before doing PCNL. So we have to make sure what is the arrangement, and accordingly we can puncture this one. So do surgical procedure, we should know this one. So this is very much about this anatomy of the kidney. Now the ureter is another important thing. So how this is not the straight one. This is important thing is, this is the curved structure. So many bendings. And the length, this is the western size ureter, that is about 30 centimeter, or is much less, maybe 24 to 26. The tall guy, it can be 30 also. So this is the rather the S curve, and you will be asked what are the narrowing in the ureter. So if there is stone in the kidney, and usually small stone, they try to come down. And remember, there are 3 narrowing. 1 natural narrowing, 1, and there is just above the iliac vessels, 2, and before they get exit into the bladder, 3. So stone, they got lost here. If they got able to go through this one, this is the side where there is another obstruction, and this is the most narrowest part. If the stone goes out from this narrowing, then they can just come out easily, usually. So this is, look at how closely these vessels are. So if you are doing surgery and if you are not careful, then you can just cut this vessel. Okay, so that's how this configuration of ureter is very important. This is the real picture of IVU, IVP. So this is the dye you can see is one narrowing, two narrowing, and the third narrowing. Okay. And another things you should know is the relation of renal artery, vein, and pelvis. So mnemonic is VAP. So you cannot afford to forget this one. V from anterior to posterior. So if you take the normal patient, you open from abdomen side. The first thing you identify is the vein, then artery, and pelvis. VAP. This is a mnemonic from anterior to posterior. It's clear? So extradural, intradural, forget about that. So the course of the ureter is very much important, of course, for the urologist and the gynecologist. So there are future gynecologists. Remember my word, the gynecologists are very much notorious for injuring the ureter. Why? Because look at this, how closely this uterus is with the ureter. So they do procedure of removing of some hysterectomy, means they want to remove the ureter. So they are very closely ureter. Sometimes they tie the ureter, sometimes they cut the ureter. So this is one of the complication of not knowing proper anatomy. And below is the bladder. So sometimes they are doing cesarean section, then the bladder is just behind that. So they will injure the bladder also. So what is the course is that they lie on the psoas muscle proximally and pass medial to the sacroiliac joint. So this is the iliac and this is the sacrum. From there they go medially and then they swing laterally near the ischial spine. So this is the ischial spine. From here they go laterally. So part of the pelvis, remember anatomy. So what is ischial spine? From there you can just they go laterally and they again enter medially at the bladder. This is the course of the zigzag course. And ureter, they are the retroperitoneal organ, means they are beside the peritoneum. They are not inter the peritoneum. So just superior to the ureter is the posterior peritoneum. And there is a vast difference. As they leave the internal inguinal ring, they just go in the lateral side of the pelvis. So there is vas also there. Now histology, just another important things. So we have to forget the anatomy, but you cannot. So if you cut this thing, then there is the calyxes, pelvis, ureter, they all are lied by the transgenal cell epithelium. So why it is different? If it is a cancer of cortex or medulla of the kidney, then it is different. It is maybe adenocarcinoma or other thing. Histological, they are different. But if it is a cancer of calyxes, pelvis, ureter, then this is the cancer of transgenal cell epithelium. This is the same cell you can see in the bladder. So bladder, ureter, and the pelvic calyxes